Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Welcome back to the deep dive. Today, we are buckling up for something pretty intense.
Yeah, we really are. It's a big one.
We are doing something specifically designed for you. The students, the crammers, the lifelong learners in the nursing field who are staring at your textbooks right now and wondering how on earth you are going to memorize all of this. Because we are tackling a beast of a topic today. We are looking at Chapter 19 from Pharmacology, a patient-centered nursing process approach. That's the 12th edition. And the topic is anti-seizure drugs.
It is a massive topic. And honestly, it's one of those chapters that can feel incredibly overwhelming.
Yeah.
Because you are dealing with brain chemistry, critical safety protocols, and a laundry list of side effects that you simply have to memorize. It's high stakes.
High stakes is right. I mean, this isn't just about memorizing a pill name. It's about stopping an electrical storm in someone's brain without accidentally stopping their heart or their breathing in the process. So our mission today is pretty straightforward. We are going to translate this dense technical material into a conversation that you can actually digest while you're driving, working out, or just staring at the ceiling trying to make sense of sodium channels.
Right. And we are going to stick strictly to the text provided in Chapter 19. No outside noise, no Googling random studies, just the facts you need to know for the exam, and more importantly, for the patient sitting in the bed in front of you.
And I really want to set the stage here. We aren't just memorizing drug names. We are learning how to keep patients safe. Because as we're going to find out, these drugs have a very narrow margin for error. You give too little.
The patient has a seizure.
Right. You give a tiny bit too much.
You're dealing with toxicity. It is a tightrope walk. And the nurse is the one holding the balance goal.
So let's unpack this. We've got a lot to cover today. Identifying seizures, how the drugs actually stop them, the specific drug classes like hydantoins, and the crucial nursing process. But let's start at the very beginning. How does the source material actually define the condition? What are we dealing with when we say epilepsy?
Well, the text is very specific here. It defines epilepsy as a chronic disorder. It results from abnormal electric discharges from the cerebral neurons.
Abnormal electric discharges. It sounds like a short circuit.
That's a really good way to visualize it. The characteristics are usually a loss or disturbance of consciousness and involuntary, uncontrolled movements. But the key word there is chronic. A person can have an isolated seizure and not have epilepsy. Epilepsy is the disorder itself.
So physiologically, what is actually happening during that short circuit?
The text explains it as a disruption in the electrical functioning of the brain. Think of your brain as a balance scale. On one side, you have excitation, so neurons firing. On the other side, you have inhibition, neurons telling the system to chill out. A seizure is an imbalance. You have too much excitation, maybe due to a defect in the neuronal membrane or an issue with sodium rushing into the cells, or you have a decrease in the inhibitory action, specifically a lack of gamma-aminobutyric acid, or GABA.
GABA. We're going to hear that acronym a lot today. That's the brain's brake pedal, right?
Precisely. If you cut the brake lines,
Meaning you don't have enough GABA.
the car speeds out of control. That is the seizure.
Wow. And the numbers here are staggering. The source mentions 3.4 million people in the United States have active epilepsy. That is a huge population.
It's very common. But here is the statistic that always blows my mind. The etiology or the cause. The text says that 75% of seizure cases are primary or idiopathic.
Idiopathic means we don't know why, right?
Correct. Unknown cause.
Yeah.
So for 3 out of 4 patients walking into your clinic with epilepsy, we can't point to a specific injury or infection. It's just happening.
That is wild and terrifying for the patient, I'm sure. So what about the other 25%?
Those are secondary causes. That means they're caused by something else. Brain trauma, ataxia, which is an absence of oxygen infection, or a cerebrovascular disorder like a stroke.
Now, the text makes a really important distinction between epilepsy and seizures that are not associated with epilepsy. Can we clear that up? Because I feel like if a patient has a seizure, they immediately get slapped with the epileptic label, and that might not be right.
You're absolutely right, and the text is careful to distinguish this. Not every seizure means epilepsy. The source lists triggers for non-epileptic seizures: fever, stress, hypoglycemia, electrolyte imbalances, specifically hyponatremia, so low sodium metabolic imbalance, and alcohol or drug withdrawal.
So if a patient comes in with ultra-low sodium and has a seizure, you don't start them on lifelong epilepsy medication.
Exactly. The key takeaway here is that if you correct the underlying condition, you fix the low sodium, you treat the infection causing the fever, the seizures cease. That is not epilepsy. Epilepsy is the chronic, usually lifelong disorder where the brain itself is prone to these misfires without an external trigger.
Okay, that's a vital distinction. And the text briefly mentions diagnostics too, right? EEG, CT, MRI.
Yes, the electroencephalogram or EEG is crucial for recording that abnormal electrical brain activity. And CT scans and MRIs are used to rule out secondary causes like lesions or tumors.
Okay, before we get into the heavy artillery of the drugs, we have to talk about what these seizures actually look like, because seizure is a broad term. The text has this table, Table 19.1, the International Classification of Seizures. And honestly, looking at it, the terminology can get a little mixed up because people use old terms and new terms interchangeably. Help us navigate this.
Right. It can be confusing. The classification divides them into two main buckets: generalized seizures and partial seizures.
What's the difference?
Geography. Generalized seizures involve both cerebral hemispheres of the brain. The whole brain is firing. Partial seizures involve just one hemisphere.
Let's start with generalized. These are the ones involving the whole brain.
The most common form, and the one most people picture when they hear the word seizure in a movie or TV show, is the tonic-clonic seizure. The text notes this was formerly known as grand mal.
Grand mal, right. And it's broken down into two phases, right? Tonic and clonic.
Exactly. And you need to know the difference. The tonic phase comes first. The skeletal muscles contract or tighten in a spasm. The text says this lasts about 3 to 5 seconds. This is often where you might hear a sound from the patient as air is forced out of the lungs against a closed glottis.
And then
comes the clonic phase. This is the dysrhythmic muscular contraction, the jerking up of legs and arms. That lasts significantly longer, usually 2 to 4 minutes.
Okay, so tonic is the stiffening, clonic is the jerking. That seems distinct enough. But what about the other generalized types? Because they don't all look like that.
No, they don't. You have the absence seizure, formerly called petit mal. This is radically different. It's a brief loss of consciousness lasting less than 10 seconds. It's often seen in children.
What does it look like to a teacher or a parent?
It looks like nothing. Or rather, it looks like the child is just daydreaming or staring into space. They might just stop talking mid-sentence, stare blankly for 5 seconds, and then pick up right where they left off. The text mentions you might see fewer than 3 spike waves on the EEG printout. But clinically, it's very subtle.
I can see how that would be missed for a long time.
It often is. Parents just think the kid isn't paying attention. Then you have myoclonic seizures. This involves isolated clonic contractions or jerks. It lasts 3 to 10 seconds. It might just be one limb jerking, or it could be the whole body.
And a tonic.
A tonic is essentially the opposite of tonic. Remember, tonic means stiffening. A tonic means a loss of muscle tone. The text describes it as a head drop or loss of posture. If the lower limbs are involved, the patient could suddenly collapse.
That sounds dangerous just from a fall risk perspective. If your legs just give out, you're hitting the floor hard.
Exactly. That's why these patients often wear helmets. Now, moving to the other bucket in Table 19.1, partial seizures, just one hemisphere.
Right. And here, the dividing line seems to be consciousness.
Yes. In simple partial seizures, there is no loss of consciousness. You might have motor symptoms like the thumb twitching, or sensory hallucinations like visual or auditory changes, or autonomic responses like sweating. But the person is awake. They are aware it's happening.
That must be surreal, to watch your own arm twitching and not be able to stop it.
It's commonly described as the Jacksonian march, where the twitching starts in the hand and moves up the arm. Then you have complex partial seizures. Here there is a loss of consciousness. The patient doesn't recall their behavior. This is where you see automatisms.
Automatisms.
The text describes these as repetitive behaviors like chewing or swallowing motions. They might look like they're acting out or smacking their lips, but they aren't aware of it. They're checking out mentally while their body performs these automatic movements.
Okay, so we've identified the enemy. We know what the seizures look like. From the violent storm of the tonic-clonic to the subtle stare of the absence. Now let's talk about the weapons we have to fight them. This brings us to the pharmacophysiology. How do these drugs actually work? The text outlines 3 specific mechanisms.
This is the how and why of the entire chapter. If you understand these 3 mechanisms, the side effects and drug classes make much more sense. You have to understand the cellular level.
Walk us through it. Mechanism number 1.
Suppressing sodium influx.
Okay, sodium influx. In plain English.
Think of a neuron like a gun. For the gun to fire, the trigger has to be pulled. In a neuron, Sodium rushing into the cell is a trigger being pulled. It causes the electrical fire.
So these drugs stop the sodium.
Sort of. The drug binds to the sodium channel when it is inactivated. It prolongs the inactivation. Think of it as jamming the lock on the door so it can't open as quickly. It prevents the neuron from firing repeatedly. It stops the rapid fire. The drugs that do this are the heavy hitters. Phenytoin, carbamazepine, valproic acid, topiramate.
Okay, so we are slowing down the trigger finger. Mechanism 2.
Suppressing calcium influx. This prevents the electric current generated by the calcium ions through the T-type calcium channel.
Is this for all seizures?
No, it's fascinating. This calcium channel is really specific to the thalamus, which is involved in absent seizures. So drugs that block calcium like valproic acid and ethosuximide are specifically great for those daydreaming seizures we talked about.
Okay. So sodium is for the big storms, calcium is for the absent seizures, and the third mechanism...
Enhancing GABA. Remember GABA?
The brake pedal.
Exactly. Gamma-aminobutyric acid. It is an inhibitory neurotransmitter. These drugs simply stomp on the brake pedal. They increase the action of GABA, which inhibits neurotransmitters throughout the brain. This includes barbiturates and benzodiazepines.
So we are either blocking the gas with sodium or calcium or slamming on the brakes with GABA.
Precisely. That is the entire strategy. And the goal of therapy, according to the text, is to stabilize nerve cell membranes and suppress abnormal impulses. But we need to manage expectations. The text explicitly states that anti-seizure drugs control seizures in approximately 70% of patients.
70%. So for 30% of people, they take the meds and still have seizures?
Correct. It's not a magic bullet. And the text says these drugs prevent seizures, but do not eliminate the cause or provide a cure. It is usually a lifelong therapy. However, there's a note of hope. The healthcare provider might consider discontinuing the medication if no seizures have occurred after 3 to 5 years.
That is a long time to be seizure-free. Now, before we get into the specific drugs, we need to talk about dosing. Because reading this chapter, I got the sense that dosing these drugs is more of an art form than a simple prescription.
It is highly individualized. You can't just give everyone 100 milligrams and walk away. The text highlights age-related considerations specifically. Newborns, people with liver disease, and older adults require a lower dosage. Why? Because of a decrease in metabolism. If you can't metabolize the drug, it builds up in your system. If it builds up, you get toxicity.
And on the flip side,
children, they often have an increased metabolic rate. They burn through the drug faster. So counterintuitively, they might actually require a higher dosage per kilogram of body weight than an adult to maintain the same protection.
That's really important for PEDS nurses to know. And then there's this concept of the therapeutic range. This seems to be the single most critical concept for nursing monitoring in this chapter.
It is of utmost importance. The text uses phenytoin as the prime example here. Phenytoin has a narrow therapeutic range of 10 to 20 micrograms per milliliter.
10 to 20. I feel like we should tattoo that on our foreheads.
Well, it's that important. Think of it as a narrow bridge. If the drug level in the blood is below 10, you fall off the bridge, the patient isn't protected, and they seize. If it's above 20, you fall off the other side, they enter toxicity. It is a very fine line. The nurse has to monitor these serum levels constantly to ensure drug effectiveness and safety.
Okay, let's deep dive into the specific drugs. And we have to start with the big one. The text calls it the prototype drug, the hydantoins, specifically phenytoin.
Phenytoin. Discovered in 1938 and still the most commonly used drug for tonic-clonic and partial seizures, it works by inhibiting sodium influx. But honestly, it is a difficult drug to manage.
The pharmacokinetics of phenytoin, the way it moves through the body, seems complicated.
It is tricky. Absorption is slow and erratic. But the big thing to remember is protein binding. Phenytoin is highly protein-bound, 90 to 95%.
Can you explain why that matters to a nurse? I think protein binding is one of those terms we gloss over.
Let's use an analogy. Imagine the drug molecules are people getting on a bus. The bus seats are the protein molecules, specifically albumin, in your blood. When the drug is sitting in the seat bound to protein, it's inactive. It's just riding along. It can't do anything. The only molecules that work, and the only ones that cause side effects, are the people standing in the aisle. The free drug.
Okay, so usually 90% are sitting and 10% are standing and working.
Exactly. But what happens if the patient has low serum protein or albumin? Maybe they are malnourished or they are an older adult.
There are fewer seats on the bus.
Bingo, fewer seats. So now instead of 10% standing in the aisle, maybe 30% are standing in the aisle, you have way more free active drug floating around. So even if the total dose you gave is normal, the active drug level is effectively an overdose. This leads to toxicity.
That is fascinating. So you could overdose on a normal dose just because your nutrition is poor.
Exactly. That's why we check albumin levels. Also, the half-life varies wildly, anywhere from 7 to 60 hours, depending on the patient.
Now let's talk about administration. The text has some very scary warnings about giving phenytoin intravenously. This felt like a do not cross line in the text.
This is a critical safety section. If you are giving IV phenytoin, you must follow the rules or you will hurt the patient. First, it should go into a large vein, preferably a central line or KICC.
And what about dilution?
This is a classic board exam question. You can only dilute phenytoin in saline, never dextrose.
Why? What happens with dextrose?
Precipitation. Dextrose causes the drug to clump up. It essentially turns into crystals or sand in the line. You do not want chunky medication going into a vein. That is an embolism waiting to happen. The manufacturer also recommends an inline filter to catch any potential crystals.
And the speed?
Slow. Very slow. For adults, the max rate is 50 milligrams per minute. For older adults, 25 milligrams per minute.
Why so slow? What happens if I push it too fast?
Rapid infusion causes severe hypotension, a massive drop in blood pressure, and cardiac dysrhythmias. You could literally stop their heart.
Wow, okay. Slow push, saline only, large vein. Got it. And the text mentions IM routes too.
It does, but it specifically says the IM route is avoided due to erratic absorption and severe tissue irritation. So stick to IV or oral.
Now, side effects. Phenytoin seems to have a list of side effects a mile long.
It does. Let's start with the cosmetic ones, which affect patient compliance. Gingival hyperplasia.
That's the gum thing, right?
Yes, overgrowth of gums. And we aren't just talking about a little swelling. The gum tissue can actually grow down over the teeth, becomes reddened and bleeds easily. It's a common side effect. Nurses need to teach patients to use a soft toothbrush and maintain good oral hygiene, but sometimes a gingivectomy, the surgical removal of gum tissue, is actually needed.
And then there's something called purple glove syndrome.
This is a serious injection site reaction. It happens when IV phenytoin leaks into the tissue. The hand becomes swollen, discolored, a dark, violaceous purple, and incredibly painful.
Is it just a bad bruise?
No. The text warns it can potentially lead to necrosis and amputation.
Amputation. Just from an IV site reaction, that is terrifying.
It underscores why that IV administration protocol is so strict. Other side effects include hyperglycemia because the drug inhibits insulin release, and nystagmus, which is a constant involuntary cyclical movement of the eyeball.
Also, harmless pinkish red urine.
Yes, harmless. But you have to warn the patient or they will think they are bleeding internally and stop taking the meds.
And psychiatric effects.
Depression, suicidal ideation, and chemically it can cause blood dyscrasias like thrombocytopenia, which is low platelets, and leukopenia, low white blood cells. So we were watching their CBC labs closely for signs of infection or bleeding.
We also need to touch on drug interactions with hydantoins. Since it's so protein-bound, I imagine it fights with other drugs.
It is a bully on the bus. It displaces other drugs. It competes with drugs like aspirin and anticoagulants for those binding sites. It displaces them, causing more free anticoagulants in the blood, which increases the risk of bleeding. Also, absorption blockers like antacids, calcium, and sucralfate decrease phenytoin absorption. And herbs, specifically ginkgo, decreases effectiveness.
So no ginkgo biloba if you're on phenytoin. Got it. Okay, that is phenytoin, a powerful drug but high maintenance. Let's move to another major player. Valproic acid.
Valproic acid is a broad-spectrum drug. It's used for tonic-clonic, absence, and partial seizures, but it has a major safety warning. The safety and efficacy have not been established for children under 2 years of age.
Why the age limit?
Hepatotoxicity. This drug carries a high risk of liver damage. It acts on the liver, so you must monitor liver enzymes. And very young children, their livers just can't handle it.
What's the therapeutic range for valproic acid?
15 to 100 micrograms per milliliter. Note that it's higher than phenytoin.
And a practical tip for the patient.
It causes significant GI distress, nausea, vomiting. So the nursing advice is to take it with food.
Now I want to pivot to section 7 of our outline. Anti-seizure drugs in selected situations. Because you don't just treat the seizure, you treat the patient in their specific life context. And the biggest context mentioned is pregnancy.
This is a major clinical dilemma. The text explains that hypoxia, the lack of oxygen that occurs during a seizure, is dangerous for both the fetus and the mother. So ideally, you want to stop seizures. However, many anti-seizure drugs have teratogenic properties.
Teratogenic means causing birth defects.
Correct. Phenytoin and carbamazepine have been linked to fetal anomalies like cardiac defects and cleft lip and palate. Valproic acid is linked to major congenital malformations, specifically neural tube defects.
So what do you do? It seems like a catch-22.
It's a balance. A neurologist consultation is recommended before pregnancy, ideally. But there's another specific issue: vitamin inhibitors. Phenytoin and carbamazepine inhibit vitamin K.
Vitamin K is for clotting.
Right. So this contributes to hemorrhage in the infant shortly after birth. They also increase the loss of folate, or folic acid.
So the intervention is?
Pregnant females are given vitamin D and K prenatal vitamins and daily folate supplements to counteract the drug's effect. And the infant gets vitamin K immediately after birth.
Another specific situation, febrile seizures. We see this in kids. High fever, suddenly they seize. It freaks parents out.
It is very scary, but usually benign. They occur between 3 months and 5 years of age. The text notes that epilepsy only develops in about 2.5% of these children. So just because a kid has a febrile seizure doesn't mean they are epileptic.
Do we treat it?
We treat the fever.
All right.
We don't always medicate for the seizure long-term. Prophylactic treatment with phenobarbital or diazepam is only indicated for high-risk patients. And again, no valproic acid for the under 2 crowd.
Now let's talk about the scariest situation in the chapter, status epilepticus.
This is a medical emergency. Status epilepticus is a continuous seizure state, or seizures that happen back-to-back without recovery of consciousness. If you don't stop it, the brain runs out of oxygen, neurons die, and death could result.
The text lays out a very specific order of operations for drugs here. Walk us through the protocol. You are in the ER, patient is seizing nonstop. What do you do?
Step 1. Stop the seizure immediately. You need speed. The drug of choice is diazepam given the 5 or lorazepam.
Why those? Why not phenytoin?
Phenytoin takes too long to work. Benzodiazepines like diazepam act fast to enhance GABA and stop the electrical storm instantly. But they have a short duration. They wear off quickly.
So you stop the seizure, but 15 minutes later, it might come back.
Exactly. So that leads to step 2. You need long-term control. So you follow the benzo immediately with 5e administration of phenytoin. The benzo stops the fire. The phenytoin keeps it from reigniting.
And if they are still seizing?
Step 3 is midazolam or propofol. And the last resort is high-dose barbiturates to essentially put the patient in a coma to save their brain.
And what is the nurse doing while all these heavy drugs are being pushed?
Watching the respiratory rate. These are all CNS depressants. Administering them slowly is vital to avoid respiratory depression. You don't want to stop the seizure only to stop the breathing. You likely have the crash cart and airway equipment ready at the bedside.
Powerful stuff. Let's quickly review the other drug classes mentioned in Table 19.2. We mentioned barbiturates like phenobarbital.
This is an older drug, long-acting, enhances GABA. Therapeutic range is 10 to 40 micrograms per milliliter. The big risks are sedation and tolerance, and you have to discontinue gradually to avoid seizure recurrence.
Succinimides, specifically ethosuximide.
A specialist. This drug is really only for absent seizures. It decreases calcium influx, range is 40 to 100. Watch out for blood disgraces and SLE, systemic lupus erythematosus.
And benzodiazepines again? Clonazepam and diazepam?
Clonazepam is effective for absence and myoclonic seizures, but tolerance develops after about 6 months, so the dosage needs adjustment. And diazepam, as we said, is the sprinter short-term effect for status epilepticus.
One more class in this section, immunostimulants. That's a mouthful. Carbamazepine?
Carbamazepine is a workhorse?
Yeah.
Used for seizures, but also bipolar disorder and trigeminal neuralgia. Range is 4 to 12. But there's a very famous food interaction here that every nursing student must know.
The grapefruit juice?
The grapefruit juice. It blocks the enzymes in the liver that break down the drug, leading to toxicity. Patients on carbamazepines simply cannot drink it.
Okay, before we get to the nursing process, the text lists some newer drugs. I just want to hit the highlights or unique features of a few of these. Gabapentin.
Used for seizures, but honestly, in clinical practice today, you'll often see it prescribed for neuropathic pain and restless leg syndrome.
Lamotrigine.
Also used for bipolar disorder. The big risk here is a rash, specifically Stevens-Johnson syndrome, which is a life-threatening skin shedding.
Yeah.
If a patient on lamotrigine says they have a rash, you stop everything and assess.
Levetiracetam. I see this one in the hospital a lot.
Very common now for partial tonic-clonic and myoclonic seizures. It has a cleaner side effect profile than phenytoin, which is why it's gaining popularity.
And topiramate.
Be aware of cognitive side effects. It can cause memory impairment and confusion. Sometimes it makes patients feel a bit foggy.
All right. We have the drugs. We have the physiology. Now let's put the nurse in the room. Section 10. The nursing process. Assessment. What are we looking for before we even give the first pill?
First, health history. Specifically herbs and current drugs. Remember the interaction with ginkgo. Remember the anticoagulants. You need to know what else is in their system. Then labs. Renal and liver function like BUN, creatinine, liver enzymes. If the liver isn't working, these drugs will become toxic fast.
Planning seems straightforward. Stop the seizures, minimize side effects. But interventions is where the rubber meets the road. Let's talk about safety interventions.
Seizure precautions. This is standard nursing care. Patting the bed rails, low bed position, environmental protection from sharp objects. If they seize, you want to prevent secondary trauma. You can't stop the seizure with your hands, but you can stop them from banging their head against a metal rail.
And oral care.
Because of the gingival hyperplasia with phenytoin, it's not enough to just say brush your teeth. Teach them to use a soft toothbrush to prevent gum irritation. It's a small thing that prevents a lot of pain and bleeding.
Administration tips.
If it's a suspension, so a liquid, shake it thoroughly.
Why is shaking so important?
Because the drug settles. If you don't shake it, the top of the bottle is just flavored water and underdose. The bottom of the bottle is pure concentrated drug and overdose. Consistency is key. Also, timing. Take it with food or milk to help the stomach, but keep the timing consistent to maintain that serum level.
Lifestyle advice is huge here too. You have to live with epilepsy.
Absolutely. No driving when initiating therapy. Drowsiness is a major side effect. You have to be seizure-free for a certain period to drive. Avoid alcohol. It's an added CNS depressant. And wear a medical alert bracelet. If you collapse in public, the paramedics need to know you have epilepsy so they don't assume it's a drug overdose or cardiac arrest.
And for our female patients.
Reproductive health. Oral contraceptives are less effective when taking these drugs. They need to use an additional method of birth control, like barrier methods. Imagine the tragedy of an unplanned pregnancy while on a terogenic drug, because the drug itself canceled out your birth control.
That is a critical teaching point. And diabetics.
Monitor glucose closely. Phenytoin inhibits insulin release, so blood sugar can spike.
Finally, evaluation. How do we know it's working?
Seizures decrease or stop. Serum drug levels are within range. And we are watching for toxicity.
What does toxicity look like clinically? If I walk in the room, what do I see?
You see a drunk person who hasn't been drinking. Nystagmus, the eye wobble. Ataxia, stumbling or loss of coordination. Slurred speech, and eventually coma. If you see that, check the level.
Let's apply all of this. The text provides a clinical judgment case study. Let's walk through it.
Okay, here is the scenario. A 26-year-old female is on phenytoin, 100 milligrams 3 times a day. She is contemplating pregnancy. She also complains of an upset stomach and bleeding gums.
Classic textbook patient. Let's break down the problems. First, family planning.
She needs to consult her provider immediately. Phenytoin is teratogenic. She cannot just stay on this regimen without a plan. She also needs to start folate immediately and will likely need vitamin K supplements later. This is a high-risk conversation. The nurse needs to advocate for that consult.
Second problem, upset stomach.
GI distress is common. The nursing suggestion is simple but effective. Take the medication with food or milk.
Third problem, bleeding gums.
That's the gingival hyperplasia. The nurse needs to explain why this is happening so she doesn't stop the drug out of fear. Tell her your gums are reacting to the medicine. Then teach soft toothbrush use and aggressive oral hygiene.
And finally, monitoring.
The nurse checks the serum levels. We need to ensure she is in that 10 to 20 range. If she's pregnant, her metabolism might change, so levels need close watching throughout the pregnancy.
Excellent. This brings us to the final stretch, Section 12, review questions. We're going to quiz you, the listener, and you, expert, based on the review questions in the chapter. This helps solidify what we just learned. Ready?
I am ready. Hit me.
Question 1. The nurse witnesses a patient's seizure involving generalized contraction of the body followed by jerkiness of the arms and legs. What type of seizure is this?
Okay, keywords are generalized, contraction, then jerkiness. Contraction is tonic. Jerkiness is clonic. That is the classic description of a tonic-clonic seizure.
Correct. Question 2. Phenytoin has been prescribed. What is an appropriate nursing intervention? A. Report a level of 18 micrograms per milliliter. B. Monitor CBC levels. C. Brush teeth vigorously. D. Stop drug if urine is pink.
Let's break it down. 18 is within the 10 to 20 range, so A is wrong. You don't report normal. C is wrong, brushing vigorously will make the gums bleed more. Use a soft brush. D is wrong. Pink urine is harmless. So it's B. Monitor complete blood count levels. We're looking for blood dyscrasias like low platelets.
Spot on. Question 3. Patient teaching for phenytoin. Which statement indicates the patient needs more teaching? A. I must shake the suspension. B. I cannot drink alcohol. C. I should take it 1 hour before meals. D, I need dental checkups.
We are looking for the wrong statement. A is correct, shake it. B is correct, no alcohol. D is correct, So the answer is C. The patient usually takes it with food or milk to decrease GI irritation, not on an empty stomach. So if they say 1 hour before meals, they need more teaching.
Question 4. A patient is having absent seizures. What drugs do we expect? Select all that apply.
For absent seizures, we are looking for the drugs that affect calcium channels or broad spectrum. So ethosuximide, the specialist, valproic acid, or clonazepam. Phenytoin is not effective for absent seizures. It works on sodium channels primarily for tonic-clonic.
Question 5. Status epilepticus. What is the drug the nurse prepares to administer first?
We need speed. Diazepam or lorazepam. We need the fast-acting benzo to stop the event now. Phenytoin comes second.
Last one. Question 6. The nurse monitors the patient receiving phenytoin for which adverse effect? Psychosis, nosebleeds, hypertension, or gum erosion?
Nosebleeds. This would be a sign of blood dyscrasia, specifically thrombocytopenia or low platelets. Phenytoin causes hypotension, not hypertension, and gum overgrowth, not erosion.
Perfect score. You really know your chapter 19.
Well, it's all in the text.
So what does this all mean? We've covered the storm of the seizure, the chemistry of the cure, and the vigilance of the nurse. I want you to think about this as you close the book today. We are trying to control the electricity of the brain, the very thing that makes us who we are. But to do that, we have to introduce powerful chemicals that tax the liver, change the gums, and alter the blood.
It really comes down to a delicate balance.
And the nurse is the bridge.
Exactly. The nurse is the bridge between the drug's chemistry and the patient's daily life. You are the one watching the monitor, checking the gums, and holding the patient's hand when they wake up confused. It's technical, yes, but it's deeply human work.
That is a great place to leave it. Thank you for listening to this deep dive into Chapter 19, Anti-Seizure Drugs.
Keep studying, keep curious.
This has been the Last Minute Lecture Team, signing off.